Hi guys! I'm going to give an audio lecture for the Chapter 5 PowerPoint. We're going to be talking about pregnancy. As we know from our previous lecture, the majority of pregnancies proceed normally with a healthy outcome, which is a beautiful newborn baby. This week in the chapter we're going to discuss situations in which a healthy outcome is a little harder to achieve because of different conditions. We're going to start with obesity and pregnancy. Some of the other things we're going to cover are diabetes in pregnancy, hypertension in pregnancy, HIV and AIDS in pregnancy, multi-fetal pregnancies, and adolescent pregnancies. Starting with obesity, however. We covered in preconception nutrition that starting off pregnancy overweight is a risk for healthy pregnancy outcomes. There are many different metabolic processes that are affected by obesity. For example, increased blood glucose level, blood concentration of insulin resistance, etc. So you've got, it's not just overweight, it's a whole metabolic picture that makes the events of pregnancy just a little bit harder to successfully navigate. Okay, however, the treatment and recommendations for obesity and pregnancy are not complicated. They're sort of common sense measures that are similar to what we would prescribe to someone before pregnancy to try and decrease their weight prior to pregnancy. However, during pregnancy, the goal is slightly different because we want to avoid weight loss. So we're sort of transitioning from a get your body at an ideal weight and lose weight if that's necessary to getting adequate nutrients and getting the right amount of calories while not losing weight. So we're going to make sure that the diet meets nutrient needs, provides all the vitamins, mineral, fiber, macronutrients that is needed to support the pregnancy. Consume a variety of basic foods. So we're not saying, anything fancy here. It's not like you need to eat sprouted wheatgrass through your whole pregnancy. It's basic foods that everybody eats, but get a variety. Participate in physical activity and keep your weight gain steady within the guidelines, and weight loss not recommended. Okay, some women have bariatric surgery to try and decrease their weight prior to pregnancy, and it may not be related to pregnancy at all. They may just be a client who had a bariatric surgery and who now is pregnant. This has been increasingly common in the past several years. I'm sorry, I just needed a drink of water. I should have told you. It's been increasingly common in the past several years. Weight is rapidly lost after bariatric surgery. Just kind of a word about bariatric surgery. There's several different types, but the general idea is that the stomach capacity is drastically reduced. So a person may have part of their stomach removed. A person may have some bands put around their stomach, like just squeezing it to make it into a smaller pouch. A person may have their stomach bypassed by connecting part of the small intestine up towards the top part of the stomach so that food goes directly into the small intestine rather than into the stomach. The end result of this is that a person who has gone through a gastric surgery may only have a capacity of a couple tablespoons of food. So the weight loss is pretty rapid. You can imagine if you were only able to eat a couple tablespoons of food at a time, how quickly you would lose weight. So that's due to limited food intake. There is some fat malabsorption, decreased appetite, and dumping syndrome that also contribute to the weight loss. A word about dumping syndrome. that you should understand is what dumping syndrome is and how it occurs. Basically, what happens with dumping syndrome is that undigested nutrients are entering the small intestine. So, for example, if you've had a bypass where food isn't sitting around in the stomach for very long, and it's just going directly into the small intestine, or if the small intestine is shorter, it has been shortened, you are getting undigested nutrients passing right into the large intestine. Those undigested molecules of food are going to attract water into the gastrointestinal tract, and if you have a big insurge of water into the large intestine, it's going to result in diarrhea. So that's what dumping syndrome is. And as you can imagine, if you're having your food kind of just like rapidly flow through and be eliminated with a lot of diarrhea, you're not going to have a lot of absorption of that food. You're going to be losing nutrients, fluids, and electrolytes, not the least of which. So dumping syndrome, a big concern with bariatric surgery. There are also deficiencies of nutrients, which again may come from the decreased intake. It may come from the fast passage of food through the gastrointestinal tract. Also, some nutrients need certain sections of the gastrointestinal tract for their digestion and absorption. For example, you may remember that with B12, intrinsic factor, which is manufactured by the stomach and is needed to absorb B12, can be deficient if the part of the gastrointestinal tract that manufactures B12 is missing. That manufactures intrinsic factor is missing. You're going to have trouble absorbing B12, which may result in a deficiency. For these reasons, pregnancy is often it's recommended to postpone pregnancy for a year or two after surgery until the body sort of returns to a more homeostatic state, that the body has adjusted for these changes, to accommodate for the nutrition needs and the calorie needs during pregnancy. It would be very hard to achieve the amount of calories you need during pregnancy if you can only eat a tablespoon or two of food at a time. So we're looking for weight to sort of stabilize, to nutrient stores to be replenished, eating habits to be stabilized before pregnancy. As with any other client, the care for a pregnant woman who's had bariatric surgery is going to be similar. You're going to assess dietary intake. You're going to assess, is she able to eat enough food is she eating enough food to maintain this pregnancy? Does her food intake need to be increased? Assess whether she needs supplements to make up for those nutrients that may be missing. You'd be doing lab work to assess her iron status, etc., and monitoring her weight gain. You'd be addressing gastrointestinal symptoms like dumping syndrome. I just want to see if I have, no. Managing dumping syndrome is largely a matter of avoiding concentrated sweets, so you're not getting a big rush of sugar into the large intestine, eating small spread out meals, so you're not getting that big dump of food into the large intestine. And again, similar to heartburn, that you take your liquids separately from your meals. As I mentioned, certain nutrients need certain... I'm just realizing that you guys can't see all the hand motions I'm doing here at my kitchen table as I'm narrating this video, so I'll try and use the cursor a little more to point to what I'm talking to. I'm not sure if that will help, but nutrient deficiencies vary depending on the type of bariatric surgery. As I mentioned, depending on the part of the gastrointestinal tract that has been affected by bariatric surgery, different nutrients have a different part that needs for their digestion and absorption. So there's no one cookie cutter recommendation for nutrients because it's going to be different for each client. hypertensive disorders of pregnancy. Moving on to a different topic. Hypertensive disorders of pregnancy is what it sounds like. When you have high blood pressure during pregnancy, there are several different types, which we'll cover each of them. This affects 5 to 10% of pregnancies with significant outcomes. It contributes to stillbirth, fetal and newborn deaths, other adverse conditions. Unfortunately, the cause of most hypertension during pregnancy is unknown, and so the cures are also unknown. Right. So, to understand hypertensive disorders, you need to understand what is happening in the blood vessels. Here's the key phrase right here. Chronic inflammation and oxidative stress lead to damage to endothelium blood vessels. Okay, so the endothelium of the blood vessels, endo means inside, thelium is like the lining, so it's the inner lining of the blood vessels, gets damaged by inflammation and oxidative stress. And what happens is that can lead to a reduced sort of flexibility of the blood vessels. They're not able to constrict and dilate in response to hormonal messages as they normally would to control blood pressure. So blood pressure may be elevated and not under homeostatic control in hypertensive disorders. So what you're seeing is that you have impaired blood flow, increased blood clots, plaque formation. Plaque formation is mostly what decreases that flexibility, isn't sort of elasticity of the blood vessels. They're more tight and not responsive to the messages to constrict or dilate. Okay, so there are a couple different types of hypertension during pregnancy. There's chronic hypertension, there's gestational hypertension, then there's preeclampsia and eclampsia. So we'll start with chronic hypertension. This is hypertension that a woman had before pregnancy. So it's diagnosed prior to pregnancy, so she goes into pregnancy knowing that she had high blood pressure, or it's diagnosed before the 20-week mark. If it's diagnosed before the 20-week mark, that means it's likely that she already had hypertension in her life. The estimated incidence is 3%, so about 3% of pregnant women are suffering from chronic hypertension, more common in some groups than in others. The nutritional interventions for women with chronic hypertension are going to be the same as, they're going to be many of the same measures as before she was during pregnancy. That we're looking for a diet that reduces inflammation, that provides nutrients, but also provides the calories needed for weight gain. Women who have chronic I want to make sure I didn't skip a slide here. Hold on. There we go. That's what I was looking for. Okay. Gestational hypertension in opposition to chronic hypertension is hypertension that occurs first during pregnancy. With gestational hypertension, there's the increase of risk of developing preeclampsia later in pregnancy, or immediately postpartum, and chronic hypertension later in life. So gestational hypertension has its own risks in regards to the pregnancy, but also increased risk for additional conditions related to hypertension. Eclampsia is a condition of blood pressure during pregnancy. It only occurs during pregnancy. The signs can be very mild, and the health consequences can be very mild, or they can be very great. For example, it can cause convulsions, seizures, and death. Again, cause is unknown. Okay, so much like chronic hypertension, It's the oxidative stress and inflammation that damage the endothelial lining of the blood vessels that can contribute to that high blood pressure in preeclampsia. You've also got several other rather serious consequences of this condition. For example, insulin resistance. So we're getting away from just that sort of very simple model of high blood pressure into adding these other conditions as well. Insulin resistance, the maternal immune system may reject the placenta or have a reaction to the placenta. You may have increased blood lipids as well. So a big host of sequelae that are related to that hypertension. I'm going to take a slight pause for a drink of water. Okay, so for preeclampsia, in the old days, we would talk about a restricted sodium diet. That is no longer true. If you look at these recommendations, you'll see that they're very similar to just the regular hypertension diet, which is the DASH diet. DASH stands for Dietary Approaches to Stop Hypertension. And the DASH diet is characterized by many increased servings of fruits and vegetables, making sure that there's adequate minerals in the diet, and a high fiber diet. The DASH diet is lower in red meat and dairy, and high fat dairy. It focuses on low fat dairy to make sure you're getting the calcium and vitamin D. So this preeclampsia diet recommendations are very similar, making sure that you're getting all the calcium and vitamin D that you need. Using a multivitamin if the diet does not provide. Hopefully this woman would already be taking a prenatal vitamin, making sure you're getting your fruits and vegetables with plenty of fiber. Again, basic food recommendations. We're not saying that any specialized foods need to be used. Moderate exercise and maintaining the recommended weight gain. So nothing really crazy as far as dietary recommendations. I think literally everybody on the planet would do well using these same exact recommendations for general health. Okay, let's take a break. Or not, you can just keep on going with the video if you'd like, or if you need a break, take a pause. I have listed here, this is kind of silly, but it makes me smile every time I watch it. It's a story, or listen to it rather. It's a story called Joy that was featured on the radio, the Moth Radio Hour. Has nothing to do with nutrition, and if you want to skip it, go ahead. But like I said, it always puts a smile on my face, and if you need a break from this lecture, take a moment and read it yourself, and maybe it'll make you smile too. Okay, if you're back from your break, maybe you got a drink of water, maybe you watched the video, listened to the recording. Here we are back. Diabetes and pregnancy, new topic. Okay, so like with hypertension and pregnancy, there are a couple different types of diabetes and pregnancies. Type 1, type 2, and gestational diabetes. Hopefully you're familiar with all three of these already. We're going to start with gestational diabetes. Again, this is diabetes that develops only after pregnancy. Hence the name, gestational diabetes. It affects 2 to 12% of all pregnancies, but of the pregnancies that are affected by diabetes, the vast majority are due to gestational diabetes. So it's the most common diabetic condition in pregnancy. So there are significant risks related to gestational diabetes, including increased risk of spontaneous abortion, stillbirth, congenital anomalies, and neonatal death. So this is a condition to be taken seriously with some very dreadful consequences. However, it can be managed. As we spoke before when we were covering preconception nutrition, to reduce the risk, you would want to achieve as close as possible for each client a body weight in the healthy range. So you're going to have less gestational diabetes in clients. I'm sorry, let me try that over again. Okay, here are the factors that are linked to an increased risk of gestational diabetes: excess body fat, unhealthful diets, and low physical activity levels. It was much simpler to say it that way than how I was trying. But as you can see, these are things we discussed in preconception nutrition, that we're trying to get to a healthy body weight range. We're trying to achieve a healthy diet before pregnancy. We're trying to maintain physical activity levels before pregnancy. All of those things can help decrease the risk of gestational diabetes. Okay, so diagnosing gestational diabetes. There's two stages. The first is to try and determine if the patient had diabetes before pregnancy. So at the first prenatal visit, you're going to be doing sort of just a general diabetic screen. We're looking at a couple different measures that can indicate the presence of diabetes. For now, this is the one I want to focus on, the hemoglobin A1C. Okay, hemoglobin, as you all know, is a protein molecule that helps carry oxygen in the blood. What you're measuring when you measure hemoglobin A1C is how much of the hemoglobin is glycosylated, which means it has little sugar crystals, more or less, coating its surface. And those sugar crystals only form with prolonged exposure to glucose in the blood. So a elevated hemoglobin A1C, in other words, more than 6.5%, is going to indicate a long-term condition of elevated blood glucose. So it's not going to depend on what your patient had for breakfast. Say they had Fruit Loops in chocolate milk for breakfast. That's not going to elevate their hemoglobin A1C. What elevates it is long-term exposure to elevated blood glucose, and that is a sign of diabetes. I'm going to cover these other blood glucose measures on the next screen, but just briefly, that you're also looking at these diagnostic criteria of diabetes to determine if the woman has diabetes prior to pregnancy. If she's showing these symptoms at her first prenatal visit, it's a pretty good guess that she had diabetes prior to pregnancy. Hopefully she's coming to see you early in pregnancy. Because think about the changes that happen in the body early on in the pregnancy. They're pretty small. So to see these measures greatly elevated early in that early in pregnancy is probably due to not due to gestational diabetes. It's probably due to existing diabetes, either type 1 or type 2. Okay. Then the second stage, remember I said this is a 2-stage process. That first stage is testing at the first prenatal visit to see if there's existing diabetes. Then at 24 to 28 weeks of pregnancy, there's going to be a second screening for gestational diabetes. So if the patient did not have diabetes at their first screening but did at the second one, that indicates that the diabetes is due to the pregnancy. It's the gestational diabetes. So again, the general idea of a gestational diabetes screen is that the woman takes a 75-gram oral glucose tolerance test. This means a drink, usually. A lot of people say it's disgusting. I had it. It's kind of like soda. Maybe slightly sweet soda, but if you look at a bottle of, say, Sprite or Mountain Dew or orange soda and look at how many grams of sugar is in the average 20-ounce bottle of those types of soda. It's not that much more than you get in your glucose tolerance drink. But in any case, so the fasting plasma glucose is measured, so before the woman takes the drink, and we're looking to see that that is less than 92 milligrams per deciliter. More than 92 milligrams per deciliter would indicate gestational diabetes. After 1 hour, the blood glucose is checked again. Hopefully, you will see that that sugar is being cleared from her system. If it's not, this measure will be elevated. If it's still more than 180 milligrams per deciliter after 1 hour, that indicates that the sugar is not being cleared from her bloodstream and can indicate gestational diabetes. A third measure is taken after 2 hours. So this is quite a boring test. Usually you're sitting around in the hospital for 2 hours while you're waiting for these tests. But after 2 hours, we'd hope that the sugar had been cleared even more. So after 1 hour, we're looking for it to be less than this. After 2 hours, we're looking for it to be less than this. Whoops. Less than this. If it's more than that, that's indicative of gestational diabetes. Okay, very similar to everything we've talked about before. The treatment of gestational diabetes is a lot of common sense measures. We're looking at nutrition and exercise to normalize blood glucose levels. So that is the main goal of gestational diabetes, is normalizing blood glucose levels. That we're not going to have big spikes and valleys in blood glucose, that we're going to have a slow, steady supply of glucose for the mother and the infant, fetus. So, one thing that we all know can reduce blood glucose levels is a low-calorie diet, however, not appropriate during pregnancy. So we're looking more to control carbohydrate intake rather than eliminate carbohydrate intake, to have our carbohydrates in even portions throughout the day rather than like one big giant dose of sugar at breakfast and then nothing for the rest of the whole day. So we're looking to control carbohydrate intake rather than eliminate or reduce carbohydrate intake. We want to avoid diets that are so low in calories that that the woman is not providing for the pregnancy. There are some oral medications that can be used in pregnancy to decrease insulin resistance. Okay, the nutrition care plan is going to be very similar for women with gestational diabetes as all the other ones that we've covered. We're going to assess first diet and exercise. We're going to, remember it's, this isn't as easy as you guys think. Remember, the nutrition care process is ADIME. Assess, diagnose, monitor, implement. Those aren't quite the right initials there, but you know what I mean. Okay, so we're going to start with assessment. We're going to see how much the woman eats, how much she exercises, assess whether that's adequate or whether it's too much and contributing to her an excess of weight gain or an excess of calories. You're going to develop a diet and exercise plan that provides enough but not too much. You're going to monitor weight gain. You're going to monitor blood glucose. And sometimes urinary ketone results, although when we discuss type 1 and type 2, you'll see that that is not super effective for treating diabetes during pregnancy. And to make sure that you're following up after pregnancy, because women who are have gestational diabetes are prone to development of type 2 diabetes after pregnancy. So this part about ensure follow-up during and after pregnancy is a nod to the fact that they may be at greater risk after pregnancy. Even though the diabetes was caused by pregnancy, once the pregnancy is over, that doesn't mean they're in the clear. Oh, well, look at that. Exercise is definitely recommended during pregnancy to help control blood sugar. Excuse me. Okay. The recommended diet therapy for gestational diabetes, like I said, is we're going to be controlling carbohydrate intake rather than eliminating carbohydrate intake. So we're going to focus on whole grain foods, high fiber foods, fresh fruits and vegetables, so minimally processed. So obviously we would prefer that our client had a fresh peach or an apple rather than fruit roll-ups or those Welch's fruit snacks that my kids love so much. Nutrient-dense foods, again, for the number of calories that it provides, a lot of nutrients. We're going to limit intake of sugars, but I want to tell you right here, as a regular, person walking around on the street, I would cry if you took away my M&Ms or my Oreos. When I was pregnant, forget it. You would not have been able to tell me I can't have sweets. But definitely we want to limit sweets. We want to have I can't think of the right word. It's not controlled. Reduced intake of concentrated sweets. So having a piece of candy now and then, having cake or cookies now and then during pregnancy, it's not like poison to your pregnancy, but definitely not a habit that you want to have on a daily basis or multiple times per day. For your concentrated sweets, you want to limit your portion size and limit the number of times per week that you indulge in treats like that. We discussed a little bit low glycemic index foods. Again, these are foods that do not cause a big spike in blood sugar. However, it is a hard diet to teach. We want to focus on healthy fats and having our food intake spread out throughout the day. Again, don't have a big breakfast and then skip the rest of the meals. Don't skip meals at all. To have your food intake spread out throughout the day. This is because your body is having a hard time regulating a steady flow of sugar into your cells, into the baby's cells. So instead of your body sort of homeostatically regulating your sugar so that there's a steady flow, you have to create that steady flow by having a well spaced out and controlled intake of food, so that you're not having a big giant dose at one time and then nothing, then a big dose at another time. You're having a meal and a snack and a meal and a snack, so you have a steady flow of nutrients. Okay, prevention of gestational diabetes is very similar to prevention of hypertension during pregnancy. To prevent gestational diabetes, you're going to want to achieve a healthy weight before pregnancy. You're going to want to be exercising before pregnancy, and you're going to want to have your any insulin resistance addressed prior to pregnancy. Okay, in contrast, type 2 diabetes is diabetes that the patient has had before pregnancy. And I don't think we'll get too much into treatment for type 2 diabetes, because hopefully a patient who has already been diagnosed with diabetes prior to pregnancy has already had some nutrition education, on controlling their blood glucose, on the diet they need to be following, on the exercise, hopefully, that they're doing. But similar to gestational diabetes, the main goal is to normalize blood glucose. We're aiming for that slow, steady stream of energy available to the mom and the baby. During pregnancy, the risks are similar to risks that a person with diabetes would face outside of pregnancy. They may experience periods of hyperglycemia, which is elevated, hyper is up, and hypo meaning down or under, low blood sugar. So those can be risk during pregnancy as well. Right here, routine testing for urinary ketones is not recommended. Let's say a word about that. Ketones come from the breakdown of fatty acids for energy. So you should know that certain tissues in the body, for example, the brain and the central nervous system, must have glucose for energy. And only a small amount of protein can be converted into glucose for energy. So as a sort of emergency backup method, when glucose is not available, for example, there's glucose in the bloodstream, but it's not getting into the cells because of insulin resistance, an emergency backup method is to convert fatty acids into glucose. And it's not a very efficient process, and one of the byproducts, another the waste product of using fatty acids to make glucose for the brain and central nervous system tissues is ketones. They're sort of the trash of this process, and they can accumulate in the bloodstream. They can accumulate in the urine. So when people are testing for urinary ketones, it's very simple. It's like a pee strip. They don't need to go to the hospital and get blood work done. They can just do it at home. What they're testing for is to see, has my body been using fatty acids for energy? If your body is using glucose appropriately, you're not going to have a lot of this trash in your bloodstream and your urine. So that's what testing for urinary ketones is all about. It's just a way of testing, is glucose getting to the cells? Is glucose being used by the brain for energy? If not, your body is using this other system, using fatty acids to make glucose, and that's not ideal. However, routine testing for urinary ketones in pregnancy is not recommended because it just has not been shown to be effective. They study women who test daily compared to women who don't test daily, compared to women who don't test at all, and there has not been shown to be a significant benefit for the women who test daily. And as a pregnant woman, I can confirm that the less nonsense I would have to do during pregnancy, the better. So this is just one less thing that the pregnant woman needs to worry about. Type 1 diabetes during pregnancy, because it's more serious, I don't want to say it's more serious, because gestational diabetes and type 2 diabetes during pregnancy both have serious consequences. But there are some additional risks for women who have type 1 diabetes during pregnancy. The mom is at additional risk for kidney disease, hypertension, and preeclampsia during pregnancy. The newborn's at risk for death, being small for gestational age or large for gestational age, having very low blood sugar within 12 hours after birth. And this is to me a really interesting phenomenon. Why would a infant who's been exposed to high levels of blood sugar, if the mom's blood sugar is uncontrolled, the infant's going to need to produce a lot of insulin to deal with that excess blood sugar. And then after the baby is born and they're no longer sort of getting that bath of maternal blood sugar, but they've still got their own elevated supply of insulin, it can really crash their blood sugar. They've got too much of their own little baby insulin and not getting that steady stream of maternal glucose. So it can really decrease the blood sugar and lead to hypoglycemia right after birth. Control of type 1 diabetes during pregnancy. Again, the goal for all types of diabetes during pregnancy is to regulate, excuse me, I'm yawning. To regulate blood glucose levels, to have those normalized and as close to the normal values as possible. To make sure that the woman is getting enough calories to support weight gain, getting enough nutrients. Some people who have diabetes are used to having very strict diets that are tied very closely to their insulin use. So we want to make sure that now that their needs are increased, they're able to successfully adjust their diet and adjust their insulin to accommodate for the increase in calories and carbohydrates that they will be needing to achieve the recommended weight gain. Okay, I know I need a break. So if you would like a second break, take a pause of the video. A couple weeks ago, I mentioned to you that I had ordered Ruby chocolate Kit Kats off of Amazon. They finally came. So I made a video of us opening them up and seeing what they're like and trying them for the first time. And you can find the video down here at this YouTube link. You do not need to watch my nerdy video. If you want to do something else to take a break, go ahead, get a glass of water, do a little meditation, whatever you like to do when you take a break. Or if you're just hardcore and you can't wait to hear me talk about the next topic, just keep on going. Here we are at the next topic, multi-fetal pregnancies. Whoop. Okay, so we discussed early on that there is a increase in multi-fetal pregnancies, mostly due to assisted reproductive technology, ART, A-R-T. With assisted reproductive technology, very commonly the woman is taking hormones or medications to increase the number of oocytes, the number of eggs that they ovulate in a given cycle. Because the greater the number of eggs, the more likely it is that one of them can be fertilized and implanted and result in a pregnancy. So very commonly in any fertility methods, that the woman would be taking ovulatory medications or hormones that increase the chances of more than one egg being fertilized. Other factors are progressively older ages. Okay, so older women have a greater risk of having multi-fetal pregnancy, and also overweight women have a greater incidence of multi-fetal pregnancies. Okay, there are risks associated with multi-fetal pregnancies. I think a lot of people have like a little awe feeling when they think about twins or even triplets. I think once you start getting more than triplets, it starts to be a little scary. But I think a lot of people think it's, a very special, wonderful circumstance, and that may be true, but there are definitely risks to both the mom and the newborns that are increased in multi-fetal pregnancies. If you read down these lists, which this is in your book, Table 5.13, if you read down these lists, you can see that there are some very serious conditions that are increased risk during multi-fetal pregnancies. A big thing, when we talked about pregnancy last week, we stressed the importance of weight gain and the importance of achieving an adequate birth weight. If you recall, when we talked about the pregnancy chapter, that the goal birth weight was 3,500 to 4,500 grams at term for a birth weight. If you can look at this table right here, which shows age and gestational weeks. So, for example, if the woman gave birth at 28 weeks of pregnancy down through 41 weeks of pregnancy, the weights that are achieved by the delivery of twins, so each twin would weigh this much. If you look, where'd my cursor go? Okay, there we go. If you look down here at a term pregnancy for twins, the average birth weight is 2,800 grams. So less than the 3,500 gram goal that we would have for like a healthy newborn weight. So we're already looking at babies that are slightly low birth weight. We'll look at this table in a second, which discusses that a little more. But also there's a greater risk of delivering sooner. So this would be ideal if the pregnancy went to term and a baby was delivered at that weight, although it does not, the average does not achieve that 3,500 gram goal. But if the babies are delivered earlier, which can be common, you can see that we're looking at birth weights that are significantly less than that 3,500 gram goal. Over here, you can look for a singleton pregnancy. The average birth weight is pretty close to that 3,500 gram goal, and the average gestational age at delivery is 39 to 40 weeks. And there's a pretty low birth weight, although it would be wonderful if we could make this less, but 6% of singleton pregnancies are low birth weight. When you look at twins, the mean birth weight is significantly less than that 3,500 gram. And just to speak a little bit about the difference, let me start over again. As you can see, the average weight of a twin at birth is 2,400 grams, which is significantly less than the 3,500 gram goal. And part of the reason is because the average age, the average point of pregnancy that the twins are delivered at is 37 weeks. So look over at this table. If they had made it to 40 or 41 weeks, we may have achieved a weight closer to that 3,500 grams. But the average delivery time is 37 weeks. So if we look at this chart, we're looking at, again, a significantly less weight gained by that time. For triplets, it's even more significant that the average triplet pregnancy only lasts 33 to 34 weeks. By that time, we're only achieving a weight gain of 1,800. When I say weight gain, I mean of the fetus, not the mom, obviously. We're looking at a birth weight of 1,800 grams, significantly less than the 3,500 gram goal, significantly less even than a twin pregnancy. And this is because not only are we nourishing 3 babies throughout pregnancy, but also because that delivery very often happens sooner than the 40-week mark. So we can see for triplets, the low birth weight rate is up to 90%. So very significant risk of low birth weight for twin and triplet pregnancies. I just want to, as a little shout out to twin and triplet moms, to point out that a singleton pregnancy results in 7.7 pounds worth of baby. If you look at twins, you're saying, oh, they're so little, they're only 5.4 pounds. But there's 2 of them. So this woman has created 10.8 pounds worth of baby in her. And if you look at a triplet mom, she has produced 12 pounds worth of baby. So kudos to her body. It's pretty amazing to me. Okay. So, to achieve the ideal birth weight, this is the goal, that we're trying to optimize the birth weights for the twin and triplet pregnancies. It's very similar guidelines to regular pregnancy, where you would assess their pre-pregnancy weight and determine whether they were below the healthy range, in the healthy range, or exceeding the healthy range for their weight, and then their recommended weight gain is going to be based on that. For a mom who was in the healthy range of weight before pregnancy, we're recommending 37 to 54 pounds of weight gain. And that would be compared to 25 to 35 pounds of weight gain for a singleton pregnancy. So you can see significantly more. And the pattern of weight gain is also increased. So we're looking at, rather than 3 to 5 pounds in the first trimester, we're looking at 5 to 7 pounds in the first trimester. And then from there on, the weekly weight gain is increased as well, where we were saying for a regular pregnancy, 1 pound a week in the second and third trimesters. For a multifetal pregnancy, for a twin pregnancy rather, 1 or 2 pounds per week in the second and third trimester. For triplet pregnancies, we're aiming for a gain of about 50 pounds. Okay, obviously during multifetal pregnancies, there's a higher calorie need. There are higher needs for fatty acids, iron, and calcium. However, studies on how much more are not really known. So how much more of these nutrients is needed is not known, and our recommendations are based on best practices. I'll say a little bit more about best practices at the end of this lecture. Suffice it to say, for now, it's not responsible to experiment on pregnant women, and that is why for many recommendations like this, we don't know for sure. We just do what in good faith makes sense, and that we have seen has been successful in the past. Okay. Yes, that's it for multifetal pregnancies. Moving on to HIV and AIDS during pregnancy. I think a really important thing to address during this discussion is that in addition to this sort of like medical condition, there are often other conditions that need to be addressed to achieve a healthy pregnancy in HIV and AIDS patients. It is more common, although not unknown, it's more uncommon in groups that are affected by poverty, and these groups may have limited access to food and health care. Because they have AIDS, they may have other illnesses as well. So it's super important in these cases to be looking at the whole picture. You can't just say to a pregnant mom who has HIV and AIDS, like, oh, well, you need to be really careful to cook your foods thoroughly, because foodborne illness is a risk factor for patients with HIV and AIDS. Because that client may not have a stove. That client may not have access to a microwave. That client may only be eating convenience foods from the convenience store. or foods at the food shelter. So you really need to know the patient. You really need to know their circumstances in order to make appropriate recommendations. So that being said, the treatment of HIV and AIDS, in the ideal scenario, well, the ideal scenario was that it wouldn't be an issue at all. But ideally, the patient has been diagnosed previous to pregnancy and is already on a course of medication, is already receiving care. However, that's not always the case. But care and treatment is needed throughout the pregnancy. It's not like their treatment of their HIV and AIDS can sort of be put on pause while they're pregnant. The consequences of HIV and AIDS for pregnancy are largely related to two factors, which we'll get to. One being calorie needs are difficult to meet calorie needs and difficult for weight gain. And the second is food safety. The HIV and AIDS virus and infection itself does not seem to have an effect on pregnancy, but the results of those infections, like for example, we're going to talk about with weight gain, have a bigger effect. Okay, so the first factor is nutrition needs during HIV and AIDS. One of the hallmarks of HIV and AIDS is a cycle of wasting, meaning the patient is sick and they have trouble eating enough food, so they have a decrease in weight. The decrease in weight can lead to increased incidence of illness. So they get sicker, they lose weight. The more weight they lose, the sicker they get. So it's a cycle of wasting, and a major goal of treatment for HIV and AIDS is maintaining weight and avoiding weight loss and lean tissue loss. So during pregnancy, double. It's very hard to keep up your appetite if you're on medications that make you feel nauseous, if you have sores in your mouth, if you're just feeling sick all the time, if you're continually getting infections from having a compromised immune system. So that is one of the major issues. The other major issue is food safety. So if you have a compromised immune system, you are more susceptible to foodborne illness. So treating food using food safety measures is extremely important for these patients, and patient education to that effect is important. On table 518 in your text, you can see, excuse me, I'm yawning again. On table 5.18 in your text, you can see some of the nutrition management suggestions for HIV and AIDS. And as we said before, making sure that other issues such as access to food and healthcare are addressed is important as well. Okay, eating disorders in pregnancy. As we discussed before, I believe, eating disorders are rare in pregnancy because most women who have an eating disorder experience subfertility or infertility. However, it does happen. You definitely can find examples of patients with eating disorders who become pregnant. A quick search on the internet, you can find some really disturbing blogs of moms who have eating disorders who are pregnant, who maintain extremely low calorie diets. It's really quite amazing. However, commonly, if a woman with an eating disorder does get pregnant, with proper care, she is able to overcome some of the challenges of the eating disorder during the pregnancy, and some of the symptoms may subside. However, it's common for them to return after pregnancy. Okay, I'm getting super nervous because my cat is walking all around the keyboard, and I'm so afraid she's going to step on it and destroy this whole recording, which I've been doing for an hour now. There. Whew. She's on the floor now. Okay. So, eating disorders during pregnancy. Very serious consequences, obviously. If you are not providing enough nutrients for yourself, never mind a baby, you're not going to have a successful pregnancy outcome. And as you can see, there are several very serious consequences of eating disorders during pregnancy. Okay, one thing that I think a lot of nutrition students are not aware of is the limited scope of dietitians in the treatment of patients with eating disorders. Bear in mind that true eating disorders are psychological illnesses, and that a dietitian does not have the training that a psychologist or psychiatrist does that is needed to address these issues. Very commonly, patients with eating disorders would be referred to a specialist clinic where there was a healthcare team that would certainly include a dietitian, but also nurses and psychiatrists, psychologists, usually psychiatrists, and doctors that are all specialized in treating eating disorders to successfully navigate a pregnancy, behavior change, dietary intake, and weight gain would all have to be addressed. And the dietitian's role might be limited to assessing current dietary intake, for example, taking a 24-hour recall, and calculating the amount of nutrients that the client is currently taking in, and then making recommendations on how much they should be taking in. And there's often some degree of negotiation where, if you tell a eating disordered patient that they need to take in 2,400 calories a day, they may laugh at you and never come back. So there may be some negotiation as far as, we want you to try to get at least this much. Ideally, you'd want that much. However, the counseling required to help these patients accept those behavior changes that they would need would very often need to be done by other members of the eating disorder team. Okay, moving on to fetal alcohol spectrum disorders. There are several types. These are all related to maternal intake of alcohol during pregnancy. Okay, so the recommendation for alcohol intake is that women do not drink alcohol during pregnancy. The fetus cannot metabolize alcohol, and so it can accumulate and stay in their system for much longer than it would in the mom's system. It's more sensitive to the toxic effects of alcohol in the first trimester during those critical periods. However, intake of alcohol should be restricted throughout pregnancy. Last topic, nutrition and adolescent pregnancy. So we're talking about teen births, which thankfully have declined significantly over the past 20 years. The major issue nutritionally with a teen pregnancy is that teens are growing themselves. So they need a tremendous amount of calories to support their own growth in height and weight, and additional calories for the growth of the fetus. Infants born to teens weigh less than those born to adults simply because they are two people competing for resources. They're competing for calories and nutrients. There are significant risks associated with teen pregnancy. please see the table in your text for these. I'm very sorry. I'm starting to lose steam. I'm sure you all are too. But again, very significant risks, and for a group of people that more or less sees themselves as invincible. I have 2 teenagers at home, and they really don't have sort of like the emotional or cognitive maturity to think ahead to the consequences of, for example, their current diet. That they do not feel that heart disease or diabetes could happen to them. Same with teen pregnancy. That these are very serious consequences that may not feel real or imminent to teens who are experiencing pregnancy, but they are very real risks. Okay, compounding teen pregnancy risks would be a pregnant teen who is overweight prior to pregnancy. She's going to have increased risks for cesarean delivery, hypertensive disorders, gestational diabetes, delivery of large infants. You wouldn't think so, considering what we just said about... I'm sorry, the cat is still walking all over my laptop. It's not easy. Okay, so we had just mentioned that the teen's body and the fetus's body compete for nutrients, but it's certainly possible to exceed the requirements for calories and nutrients, and that because the teen's body is not homeostatically mature, they may have additional difficulty navigating weight gain and the consequences of excess weight gain. Okay, so simply, pregnant adolescents need more calories to support their own growth and the growth of the fetus. If you're familiar with the diets of many teens, you will find a lot of highly processed foods, convenient foods, a lack of fruits and vegetables. So these would be issues that need to be addressed and educated on the concept of nutrient density in food choices. Okay, this is the last slide. Thank goodness. And it was just one last word on what I referred to earlier about best practices and evidence-based practice. And that is to say that evidence-based practice is protocols that are suggested by research. So how much iron do pregnant moms need? Well, research shows that blah, blah, blah. How much fiber does the average healthy adult need? Research shows, they need about 25 grams of fiber per day. It's not ethical to experiment on pregnant women, and so the research needed to support evidence-based practices not always there. In those cases where we don't have evidence-based practices to rely on, we need to use best practices. Best practices refer to the best of our knowledge, in good faith, in our experience. We see that these are the practices that are least likely to do harm. So it's important to distinguish between those two types: evidence-based practice, for which there is research to back it up, and best practices, which are just our best guess for what's the best thing to do. So thank you for making it all the way through this lecture. If it makes you feel any better, I had to do it twice because of that first one not working out. So for whatever agony you suffered through in this lecture, I've done it twice. I hope it was helpful to you guys. I hope that it helps us cover that material we missed in class on this week. And I'll see you in class on Wednesday. Thank you.